Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring a really interesting discussion that is relevant as the COVID-19 vaccine is just now rolling out across the world, really. Of course, the US, it just rolled out. And I'm excited to talk about some of the technical challenges associated with it, the interoperability challenges, the patient identification challenges, and everything associated with it. And we have a great panel with us here today. So we're going to go around the panelists and have them introduce themselves. Drew, do you want to kick us off?
Sure. I'm Drew Ivan, the Chief Product and Strategy Officer at Lyniate. We're a company that focuses on healthcare interoperability.
Awesome. Great to have you here, Drew. Matthew, you want to go next?
Sure. Thanks, John. I'm Matt Mccall. I'm the President and CEO of Life Image. We're a very large global-based evidence network that moves medical information around from institution to institution, provider to provider, patient to patient, et cetera, focusing as a dominant use case in hard to acquire non-interoperable, unstructured data in imaging.
Awesome. Great to have you here, Matthew. And Laurie, you want to go next?
Yes, I'm Laurie Peters. I'm the HIE Client Director at Orion Health. And Orion is a leading population health management company and one of the world's foremost providers of integration solutions for healthcare organizations.
Great to have you all here, and excited to hear your perspectives on what is, it's really a pretty groundbreaking, phenomenal thing that we've been able to get a vaccine this quickly. But I don't know if we went so far as to plan, okay, how is this going to be rolled out? Not logistically, which supply chain, all that has its own problems, but how are we going to track it? How are we going to know it? So hopefully today we can dive into some of the challenges we might face. And quite frankly, let's start off, is the COVID-19 vaccine rollout going to be a mess? It feels like, the more I've talked about it, the more complexity I see when it comes to technically interoperability, patient identification. What do you think, Laurie? What's your take on how this rollout's going to go?
Well, I think the initial rollout is going to not be a mess. I think we kind of have a slow rollout to start. The government has identified certain high-risk individuals that need to have the vaccine first, healthcare workers, long-term care residents, and things like that are already in a system. They're in an EMR, things like that. So what I think is those individuals are going to get their initial vaccine and follow-up. All that data is going to flow into their EMR, and then it's going to be subsequently sent to the immunization registries in the applicable states and go from there. I think after this initial rollout, we could have what you term as a mess.
That's the technical term, I think, for it. Yeah, Matthew, what do you think? To me, that's a great point from Laurie that, the initial one is from employees of health systems and very targeted people that largely have a health record. But, it gets complex really quickly. Where did you get the vaccine? Which vaccine did you get? Did you get your follow-up? What are you seeing, Matthew?
Yeah, I would agree with Laurie. I think I'm not too concerned about us being able to administer, the vaccine. And frankly, the closer, right, that the decision making gets to the provider level, as they are looking at an individual patient and making the decision as to whether it's appropriate or not for that individual patient, I'm not concerned. We've been doing this a long time. The scale itself is unbelievably impressive. But I think we'll be able to do that. I think the issue is going to be the non-interoperability around medical records for follow-up, for adverse events, being able to understand them and track them and evaluate which populations that might occur in is going to be hampered pretty materially by the lack of interoperability of medical information, right? I think the key here is if you're getting the vaccine from a provider that you know and that knows you, odds are the data is going to be in one place and is going to be good to go. But our vaccine system in the country is entirely kind of a separate silo from the medical delivery system in many regards. And people are going to be getting these vaccines as we look out of this first wave that'll happen inside a hospital generally. Here into pharmacies, into pop-up tents, into underserved communities where it'll be the Wild West, right? Being able to know who got it, when they got it, just as you had described, because the locations are just not connected across the board.
Yeah, no, that's a great point. And I think also, there are immunization registries in pretty much every state, I think every state, but they're all so different, right? I mean, speaking of lack of interoperability, it's almost like 50 countries when it comes to immunization registries, which is probably a topic for another day. But Drew, what would you add to this discussion? Let's, maybe take it a step further. How do you think most healthcare organizations are going to track and report COVID-19 vaccinations? What technology are they going to need to really do this effectively?
Yeah, well, I think both points are right. That first of all, we'll benefit from the scaled up rollout of the vaccine. Whether or not we'll take advantage of that runway to improve the interoperability remains to be seen. I do think that the interoperability piece will be difficult, especially since to deploy the vaccine at scale, we'll need to do a lot of the administration outside of the traditional healthcare settings in the pop-up locations and the pharmacies, which are not necessarily well connected to the main medical records. But, not to be cynical about it, but, is that going to be any worse than the state of interoperability we have already for other things? I mean, it's been repeated so often that it's starting to become, a trope in healthcare that when you go to a doctor, even if it's one you've seen before, the first thing they do is ask you to fill out the medical history and tell them what your medications are. I think that's going to be the same thing with the COVID vaccine. Is when you go to a new doctor, they'll ask you, "Have you had your COVID vaccine?" And they may ask you for whatever information you have about where you got it, or the dates, or the brand if you know it, or maybe we'll end up with vaccination cards like we had in the pre-computer days when childhood immunizations were tracked on paper on a little card that you had to have in order to register for summer camp or for elementary school. It could go back to the same technology as that.
Yeah. I mean, I love the idea of HIE of one. I mean, I think patients understand that because they've had to do that for a long time. And you're right. They are, I think that will frustrate a lot of patients, though, that they keep getting asked that. Laurie, I'd love to hear your thoughts from the HIE perspective and their role. Is the problem there in being able to fully do that is that HIEs are not ubiquitous? Is that the problem? And so in some areas it will be successful, or how do you see what HIE's role in kind of helping healthcare organizations track this?
Well, unfortunately, from an HIE perspective, across the country, the organizations that are part of the HIE that see the benefit of interoperability are the already established healthcare organizations. So the large IDNs, clinics, primary care clinics, and things like that. Where we're going to run into problems is what we call non-traditional providers of care. So your pharmacies, where I do believe a lot of the vaccines are going to come from, correctional facilities, public health units that right now don't have a standardized EMR or location for tracking that information. And so trying to get that information into an HIE and then subsequently to a state is going to be a challenge, no matter who it is or where it is. HIEs can fill that role if we can just get that first initial setup for those non-traditional areas, and then it's automatic from there.
Yeah. That's a great point. Matthew, I think it's interesting you exchange data on something much more complex than a vaccination record, right? Like, I think as a patient looking at this, it's somewhat embarrassing that we're not more coordinated, honestly, that we can't exchange a vaccination record. You deal with this, obviously. So, I mean, to me, is it really a technology problem? Is it really just our health system issue that's making this not happen?
Well, it's not a technology problem in the sense that being able to understand the data types and standards that would be in a vaccination registry are known, and they could be moved anywhere. So it's not a technology question in that sense. It's a technology question in the sense that our underlying system itself isn't established to be interoperable and to talk to each other, right? So here, I live outside of Boston. I've been tested for COVID-19 a handful of times since the pandemic started. And the pieces of demographic information, right, that are required by my state in order for me to receive that vaccination is an email and my phone number. And they communicate to me directly on whether I am positive or negative. And I'm the only one who understands that information because there's not a single provider or EHR set up across the system that actually communicates with me by email or by my cell phone. And so that data sits over here when it should be over here. And so it's not that I can't get tested, or it's not that I can't get a vaccine, or it's not that we can't figure out how to identify a yes or a no, or what vaccine it is. The issue is that it sits somewhere else here, and that across all 50 states and within given states, it may sit in many different else's, places here. So on an individual basis, right, again, other than, which I think we have a real problem in getting vaccinations into underserved communities, put that aside, right? If we're talking about the general structure of the system, I'm not overly concerned that people won't be able to get vaccines. I think the issue is from a public policy point of view and a population basis, understanding, right, who's gotten it, who hasn't, what stage it's at, and how to redirect those resources so that we can get, ahead of this pandemic and eventually get to a place where enough people are vaccinated that we can manage this rate. That's really the problem here that I think our technology environments in healthcare, can't solve. And I think that Drew really answered this question, which is very likely the most effective way to do it is to get a piece of paper, right, for folks. And that's tragic, right, to think that that's what we're doing in 2021 when we have such fabulous, technology. But we're not talking to each other. And when we focused, I think, as a country here on getting the science behind a vaccine, right, put together so we could deliver it, it unfortunately, right, lays on top of this non-interoperable healthcare system where we can't even get a unique patient identifier or demographics established. And laying on that foundation just exposes the weaknesses in a, coordinated, national response for this.
Yeah. And is that the obstacle you see, Drew? I mean, is that really the challenge? Because if I'm a governor of a state, a patient walking around with his slip that says, here's the vaccine I got, doesn't help me to understand, reopen things, should we reopen? Should we not? How much of the state is vaccinated? I mean, I think that's the data that they need. Is that what you see? Or do you see other challenges that, public health agencies and the healthcare industry is going to face?
No, that's exactly right. I mean, the paper does a great job of satisfying the need for an individual to prove that they've been vaccinated for whatever reason, for returning to work or getting on a plane or whatever. But what you lose when you keep records that way is the ability to query that data on an aggregate level. So you can't do things like figure out the percentage of the population that's been immunized, or figure out, where geographically the immunization has or hasn't been distributed. You lose the ability to do any of that higher level analysis. And I mean, that's another weapon that we can use against the pandemic is the information technology that comes from being able to understand that data. And if we don't have that, then that's one less tool we have in our toolbox.
If I could add, though, and I agree with you completely, Drew, is we could do both, right? And I know you wouldn't disagree, right? Is having a piece of paper or having it on my cell phone that's identified it, and pushing that out from a public policy point of view that says, well, you can't go into a restaurant without one. You can't buy a ticket to a public event without one, right? That's not the answer to the question, but it is a complementary way of us allowing, right, transactions to occur across the economy with some measure of safety, which then alleviates some of this, ancillary, damage that's being occurred by the pandemic. Doesn't help on a population basis, but it can. But it's a pretty although primitive, but really effective tool, right? We use licenses to buy liquor and to buy, cigarettes and to register for marriage licenses, et cetera, et cetera. At that level, right, it's a useful tool until we solve this more systematic problem.
Yeah. Completely agree.
Yeah.
Well, and it's interesting to compare it to licenses because you can already see the fake COVID card coming up, and how do you know if it's real or not? Although it seems like the core of what you just described, Drew, is a lack of interoperability. It's really what's hindering us in many ways, especially from the population health perspective. But it could also be from a licensing, if you will, that you've, like proof of COVID vaccine. Is that the problem? And will we see new interoperability, happen because of everything that's happening with this? Or do you think that, we ride with what we have and there's not going to really be a big push to add new interoperability right now?
Good question. I mean, I would like to think that that every challenge is an opportunity to improve our capabilities. What we've seen with the pandemic is that it has moved so fast that we can't really develop new responses. We have to go to work with the tools that we have. That's why telehealth took off so strongly when the pandemic started, because we didn't have to invent it. It was already starting to take off before the pandemic, and we just had to accelerate what we were already working on. So, I guess the way I would say it is, if we didn't have the technology at the start of the pandemic, then it's probably not going to get developed in response to the pandemic. It has to be something that already existed that we can accelerate.
Yeah, that's interesting. And Laurie, I mean, I guess you already said, well, if we onboard all these pharmacies, it would solve some of the problems and create new interoperability. Would that be a boon to the future, I guess, when it comes to that? And is that the kind of change that you think will happen on the interoperability side?
Yes, to your question, it would definitely be amazing to have all of that information flowing into a central source and then queryable across the country. One of the key things I was going to piggyback on, though, is the patient through all this, or the individual. Much like what we saw with COVID, the disease or the virus, it came up fast. We don't know exactly how it affects different people and things like that. And we didn't have the ability to capture that real time because of interoperability. Vaccines, no different. Yes, it was created very quickly. We don't know how people are going to react to it. And we have to have the ability to capture that clinical information so that we can make it better, improve upon it as we go forward. And interoperability is key to make sure that no matter where those people get that vaccination, those vaccination outcomes, I'm going to call them, are captured so that anybody that accesses that information or needs that information can access it and move forward from there. And then to Drew's point, aggregate it so that we can learn from all of this. As Matthew said earlier, this is unprecedented. This is affecting the whole, countries, not just country. And so we should capitalize on this and learn from it as much as we can.
Yeah, it's unprecedented how many times we've said unprecedented this year. It's a really great point, right? And I think, are we going to have the same challenge that we had with the testing, where there wasn't the right demographic information, or it wasn't done in a codified manner that allowed us to do the analysis? Are we going to be missing data on which vaccine they got, right? I mean, are we going to deal with those same challenges? Because, we had that in the testing. We're like, okay, you got tested, but I have no idea your gender, your ethnicity, a lot of those things that should have been passed. Are we going to suffer those same challenges with the administration, Laurie?
My initial thought is no. I think the pandemic happened really quickly and people just reacted as best they could, especially at the state level, and created these processes with little information and just trying to get things out there so we knew a baseline. I think the vaccine rollout is going to be more structured. I think we know the amount of vaccine we're getting from the companies. We know the details are all marked on there. I think it's going to be a little more controlled. Maybe in 6 months it won't be like that, but I think at least initially we're going to have a really good time period where we can develop good processes and go from there.
Which is pretty good. I mean, those first 6 months of doses is where we're going to really understand the impact. Are they effective? Are they not effective? So that's interesting. Matthew, are you going to chime in?
Yeah, I would. Thanks, John. I think I agree with everything that Laurie said. And I think, again, I'm highly confident we're going to be able to get it out there and that we're going to know who took what dose and who took one dose of which vaccine, et cetera. I think the thing we're going to miss, and I don't know that we could solve this problem right now. It's as we're dosing people, since in many regards it'll be a cursory level, right, of your medical background and history and a few core questions. And as we look at outcomes for that, and we look at medical consequences and tying those two, is it really attributable to the vaccine, right? There's certain things that you understand there's an allergic reaction, right? But when you think about effectiveness of the vaccine, and we do it at this scale, right, we don't know if how it's going to affect someone that has stage 2 diabetes, and is that different than someone that has a non-small cell lung cancer, or someone that has these pre-existing conditions, or some other underlying medical condition, or if their medical condition progresses post vaccination, a month from now, right? Is there some correlation, right? We're not going to have that underlying clinical data on a population basis broadly enough, I suspect, to quickly understand and adjust. So from a pure vaccine point of view, is it 90% or 94% effective here? Yeah. But is it causing other consequences that 90 days from now and 180 days from now? I'm just not confident we will have that data to be able to understand it. In the UK, we understand they started to administer and see allergic reaction. And they may actually be in a slightly better position since they deal with NHS and a more unified medical record system. But I think that that's part of this follow-up exposure, right? It's not about getting the vaccine, getting the population vaccinated in a way that's safe, and everybody should take the vaccine right here if your doctor suggests it for you. But it's really the more complexity of that over time that I'm concerned we're just not set up to understand, identify, and do research on that rapidly. And I'm not sure that it's on the agenda right now either for folks.
No, it probably is in very specific silos, but lack of interoperability bites again, right? That feels like what you just described. Drew, what are some of the solutions to avoid some of these challenges? What are some things you'd suggest to provider organizations, et cetera, to address some of these things?
Yeah, so for sure, the best thing to do is capture as much information as you can, because at the point that the vaccine is administered, that's when you have the most information, and if you don't capture it, then it's probably gone forever. So even if you can't interoperate that data, capture it locally, and then you'll have it available for analysis and potentially to send somewhere else when the need or the capability arises. So I guess that's the main thing. The other good advice is always to be thinking ahead in terms of what you'll want to do in the future and what capabilities you need to put in place now to enable that. So whether that means improving your technology or your the tool sets or the training that your people have, put all that stuff in place now so that as the needs arise, you'll be well positioned to react.
Laurie, any other solutions you'd offer?
Well, with my background in health information management, we're in an area right now where we're focusing on the patient and patient engagement or individual engagement. And so, another solution that we might consider is turning it back over and having the individual take ownership to some degree in that. The digital front door is something that's really getting a lot of press right now, and that kind of puts it back on the patient or the individual themselves or the individual representative to do their own research from credible, trusted resources. Know when they got their vaccine, when their provider has vaccines available to them, getting alerts to them individually. So I think that could be something that we can anticipate happening over the next short-term period.
Yeah, I think it's going to be interesting to, it's hard for me to understand because I live in the bubble. I think you guys do too. And then we've seen the vaccine, we've seen the names, we understand some of the processes. I'm excited to hear how my mom thinks about it right now. My sister, who kind of lives off the grid almost, like, how do they understand it and how do they respond to it? To your point, right? Are they going to be educated in, I got the Moderna one and it only needs this many doses, and I got this batch of it. Are they going to become that sophisticated or not? Is an interesting question. Matthew, any other solutions? And maybe let's take a look ahead, right? Like, what will this look like 6 months from now, when hopefully a large portion of the country has had the vaccine and many more are still getting it?
Yeah, I think the way that I think about this, Dennis, I think that we've had a year, and maybe this is just how we normally react, where we're addressing the crisis that we're in and the crisis in front of us, right? And we've had that. We had the initial rollout and not knowing what it meant, and then we had therapeutics and did they work or not? And now we're in a phase of, hurry up and get hundreds of millions of doses of vaccine out here. I'll bring it back to what can we do, right? At the technology level, at the provider level, right? We're dealing with the crisis in front of us, and there's nothing wrong with that, right? We have to. But as a system, here, we shouldn't take our eye off the ball, right? I'll continue to advocate for more interoperability and people recognizing, right? These are the healthcare IT professionals that sit inside these institutions every day, trying to figure out, who do I work with? What are the vendors? What are the integration points? Is my EHR doing enough here? They're the ones that I would suggest have to be thinking of the individual patient and addressing the basic questions. How do I know more about this patient that I know sitting inside my institution? How do I figure that out and get external data in? Because if they can solve that problem from a technology point of view, the clinicians will have what they need to do what they normally do, right? And, I think we've been struggling, right, as an industry this year, just to deal what's in front of us on a healthcare, even technology basis of, okay, telehealth, right, here, or in my case, right, organizations that are coming and saying, digitally connect me, right, to or my referral network for new types of data, et cetera. It's leaning into that very aggressively because we will be through this vaccine, right? I don't know whether it will be, 6 months or it'll be 18 months, but we will be through this massive phase and this bolus, and we're going to have the next healthcare crisis, and we're going to have the follow-on clinical care for these patients, right? We have millions of patients that have been affected by COVID-19 that haven't even gotten to the post-acute, right, treatment that they're going to need, right? Managing for potentially years, if not, a decade, on the impacts that have happened to them because of this disease. We're not focused on that right now because it's not in front of us immediately. But if we don't lean into interoperability very hard, those problems are going to be the next crisis and the next crisis and the next crisis, even if we're lucky enough not to have another pandemic soon here. And so that's what I would say is, let's going forward, let's recognize that the government set a foundation for us with the ONC and dealing with patient data blocking, et cetera, but it's not enough, right? We really have to, as an organization, a system, and for individual healthcare organizations, strategically recognize that this is the only way to manage these things going forward here, is to insist on your partners on solutions, interoperable solutions here, and leaning it hard into them.
Yeah, if we can't make it interoperable in the crisis, is there any hope? I guess is an interesting question. Drew, anything you'd add 6 months from now? What are you looking at?
Yeah, that's a great point. That the chronic problems that are caused by by having had COVID, we don't even understand them yet, and that's going to be an ongoing health concern. Public health concern for years to come. And, over time, that will drive a need for interoperability because as people get older and move around, then their data will have to follow them, so that proper care can be administered. So that's a longer term concern. Your questions about the 6-month time horizon, and I think that should, it's an interesting perspective, because by 6 months, I think we should start to see results. Hopefully sooner, but for sure by then we should start to see what the end game for the pandemic will look like in the U.S. and around the world, and we'll understand whether we're starting to close the door on the outbreak, or whether there'll continue to be flare-ups for a continued period of time. And if so, what does that look like in terms of how we respond? So I think the next 6 months will be a pivotal part of our reaction to the pandemic.
Yeah. Laurie, anything you'd add for the next 6 months, or any final thoughts on things we should watch for, or we should be doing to make sure we're as prepared as possible for this future?
I think what everybody has said up to this point, I agree with 100%. I think, a wise man once told me, healthcare doesn't stop at the borders. And so interoperability is a must as we go forward. And COVID-19, the disease, the pandemic, kind of solidified that for everybody. And now with the vaccine coming out, it's just another example or use case of why we have to get everybody on board and try to get them working together and sharing that information for the good of the patient going forward.
Yeah. I think if one thing the COVID-19 pandemic has illustrated is how interconnected we really are. I don't think most of us realized it. I think we kind of superficially understood it, but now, I know I've seen firsthand how much overlap there is between all of us and how interconnected we are. So thanks so much, all of you, for participating in this discussion. And hopefully, I know I learned a lot about some of the challenges that we have ahead, and also some of the solutions and some of the ways that we can help hopefully improve the rollout of the COVID-19 vaccine. So again, we've been here with Drew Ivan, Chief Product and Strategy Officer for Lyniate, Laurie Peters, HIE Client Director at Orion Health, and Matthew Michela, CEO of LifeImage. Thanks so much. Appreciate it. If you want to find more great video and health IT content like this, be sure to check it out at healthcareittoday.com. Thanks, everyone.
Thank you.